This is a session on looking at essentially steroids and steroid replacements and the whole sort of inflammation problem that's in muscle. Our first speaker is Joanne. There she is. Good. All right. Joanne Donovan. Joanne works with Catabasis and the Italfarmaco, and I think I even mispronounced it. So Joanne, you're up.
Yes, you got it. So thank you so much for being here. It is always an incredible time to come here and to hear from people like Stacy and all of you, because it gives us the inspiration and the passion to go back and to work incredibly hard to do what we can for you and your families. So thank you for that. What I'm going to talk about today is itasolonexant, which we are developing as a NF-kappa B inhibitor, and we have it in phase 3 for boys with Duchenne. First, we're a public company, so I'm going to talk about things that may happen in the future, so we show this. First, I'm going to tell you a little bit about why we're developing itasolonexant and how it works, and then tell you what we have seen in our phase 2 MOVE-DMD trial in young boys with Duchenne. We are also now doing a phase 3 study, Polaris DMD, and I'll tell you a little bit more about that and the criteria for enrolling. And we have recently opened Galaxy DMD, an open label extension for both these trials. Now, we are developing itasolonexant because we believe that it has potential to slow disease progression for all those affected by Duchenne, regardless of mutation. This is an oral therapy that we hope to have as a foundational therapy for all of those affected by Duchenne from the time of diagnosis throughout their lifetime. And we're starting with the phase 3 program that we have currently ongoing. It's being developed for treatment alone as well as in combination with dystrophin-targeted therapies that you've heard about, like exon skipping and gene therapy, because one thing alone is unlikely to solve everything about this disease. In our phase 2 MOVE-DMD and open label extension, we saw that itasolonexant substantially slowed disease progression compared to an off-treatment control period. And of course, right now, itasolonexant is an investigational agent and it's not approved in any territory. So how are we doing this? We're doing this a little bit differently. We are looking to develop itasolonexant with broad therapeutic benefits. Now, it's an NF-kappa B inhibitor. You know that the boys are born without dystrophin. But what happens with mechanical stress on their muscles, NF-kappa B is activated very early in life, within the first few months. And yet, you have muscle function that is relatively normal for several years. And what's happening then? So the NF-kappa B activation is really central in the disease progression, both in skeletal muscle as well as cardiac muscle, and it's a key link. So that's why we are targeting that. We are targeting it to affect skeletal muscle, but we also think that it has benefits in the heart for cardiomyopathy based on preclinical studies, and potentially for bone as well by decreasing inflammation. And our vision is to have a broad positive effect. We actually asked clinicians and members of the Duchenne community in qualitative research what they would like to see in a therapy, and they echoed this, that they want to see something that can affect not just skeletal muscle, but beyond that. Now, turning to the MOVE-DMD study. The study was designed to understand how itasolonexant works and to be able to design a phase 3 study for registration. We designed it and enrolled 31 boys, age 4 to their 8th birthday, who were not on corticosteroids. And we designed the study with an initial period, but then an off-treatment period And that off-treatment period allowed us to see how the boys were changing in terms of their time function tests and other functional tests. And what we planned to do was to then compare what happened off treatment to what happened on treatment with etasolinexant. We enrolled 31 boys. They're now an average of over 9, and they had 26 different mutations. So this gives a range of the endpoints that we studied in the trial. We first looked at NF-kappa B and how it was affected in white cells, and we wanted to see, are we targeting NF-kappa B? And we were able to show that in these boys. And then moving on to biomarkers that you're aware of, we looked at biomarkers of inflammation like CRP and saw a statistically significant reduction. We looked at biomarkers such as muscle enzymes, CK, that you're familiar with from clinic, and we saw that was reduced by about 30% statistically significantly. We looked at muscle MRI and worked with the imaging DMD group that in order to be able to see changes, subtle changes in the muscle, that would allow us to see this in a relatively small number of boys. And this looked at MRI T2 as well as muscle fat in the lower leg. And then we also looked at function, things like the North Star functional ambulatory assessment as well as timed function tests. The North Star, as you know, is got 17 different components that are looked at by a trained observer. And we also looked at time function tests like the 10-meter walk run, 4-stair climb, and time to stand that are age appropriate. What we saw here was that etasolinexant was able to stabilize muscle function. And this graph shows these 4 graphs with the North Star, the 3 time function tests. And up is better, higher North Star scores and higher velocities of performing the time function test. What we saw off treatment in the gray bar was that the boys in this study, and you know boys vary a great deal, but the boys in this study were declining off treatment, and the velocity of performing those time function tests was going down. We also looked at natural history data from imaging DMD and saw a similar change in boys not on steroids in this age group. When the boys were started on etasolinexant, we saw a change in the trajectory, and we saw that all 4 of these measures were stabilized over now up to 72 weeks. And remember, these are boys that are not on steroids. We looked at MRI, and MRI is there's a lot of emerging data that it correlates very well functional measures with MRI measures. And here, an increase in MRI is bad. It shows disease progression. The gray bar shows that off treatment, we saw that the boys were progressing before they started on etasolinexant. And on treatment, we saw that, again, they were stabilized. And we saw that continuing in a statistically significant way, and we saw it continue out to 72 weeks. And this is very consistent with what I showed you on the last slide with the functional measures. And this gives us confidence in moving ahead into the phase 3 study. Now, safety is incredibly important. We heard that earlier this morning. And we've now looked at boys with over 50 years total of exposure. The side effects have been mild and transient. GI is the most common side effect. And we've also seen, we measure growth in these boys. We've seen that the boys are growing along their normal growth curves in terms of height. They're gaining weight, but they're gaining it age appropriately. And in fact, overall, their body mass index, their weight for height, is actually coming down towards normal. So we are, based on this, we were able to design the phase 3 study, Polaris DMD. This is a 12-month randomized double-blind placebo-controlled study of etasolinexant versus placebo. 2 boys get etasolinexant for every boy getting placebo. And we're planning on enrolling about 125 boys between the age of 4 up to their 8th birthday. The boys need to be off corticosteroids for at least 6 months. And because of the safety we've seen in the trial to date, we're able to have clinic visits only every 3 months. We've including safety measures that also assess things like heart function and bone. And the overall safety is overseen by a safety monitoring board. And I'll tell you more about the open label extension a little bit later. Now, we got a lot of input from the advocacy community, from Parent Project, as well as families and physicians, with the aim to try to make the burden of trial participation as low as possible. We're looking at measures that reflect everyday life, activities that are important to families, and age-appropriate time function tests as well. We're not including 6-minute walk, we're not including biopsies, and we're not including MRI in this phase 3 study. What we have seen to date preclinically is that there is potential for etasolinexant to be given along with exon skipping therapies. And on the bottom left here shows this is in MDX animals, in the absence of an exon skipping agent, EDASA doesn't produce dystrophin. But in combination with an exon skipping agent, it almost doubles the amount of dystrophin that's produced. So we allowed boys in the MOVE-DMD extension to start on Exondys 51, and we're allowing boys on a stable dose of Exondys 51 to enroll in the Polaris DMD study. The etasolinexant is an oral drug. It's given as a capsule 3 times a day with food. And we have 2 different capsule sizes, so the smaller boys can take it more easily, the size of a Tic Tac or the size of a small jelly bean. And we also provide a Medi-straw, which facilitates swallowing for the boys to get started. But they've actually done very well. We're also looking at growth. We're looking at heart measures because we've also seen preclinically a benefit on the heart, and we've seen some suggestions in terms of heart rate changes in the trial to date. We are also looking at bone measures. We know that's important, and looking at DEXA to look at bone density, as well as X-rays of the spine to look for fractures. We have almost 40 clinical trial sites that are active in the United States, Europe, Israel, and Australia. We are more than 90% in terms of identifying the boys. In fact, Europe is at capacity. Canada, the United States, and Australia are enrolling, and we anticipate completion of enrolling in the coming weeks. Travel is provided for families. Now moving to the Galaxy DMD study, that is an open label extension encompassing boys from both the MOVE-DMD as well as the Polaris study. We have reduced the visit frequency further to 6 months and are continuing to look at primarily safety. The boys in MOVE-DMD are transitioning now, and once the boys in Polaris reach a year, they will start in that. Basically, the inclusion criteria is completion of the study. We are also allowing siblings of boys who completed MOVE-DMD and Polaris to be included with a broader age range. And this is because we heard from families that they wanted their sibling to also be enrolled in the study, so we're providing that opportunity. So lastly, I'd like to introduce you to the Catabasis team. We are an incredibly passionate and inspired group that is looking to develop etasolonexin as an oral foundational therapy to slow disease progression in all those affected by Duchenne, either as a single agent or with the potential to be co-administered with other therapies. We're also working to design future clinical trials to involve and to understand the effects in other age groups. And we anticipate having our data from the Polaris study the second half of next year. So in the future, I'll be back to tell you more about that. I'd like to thank you, particularly the families who have given so much to be in the study, as well as the investigators, the site personnel, and Parent Project. And there's places to follow us, both on social media as well as our website, if you want more information. Thank you so much.
Thanks, Joanne. Our next speaker is Brian Pfister. Brian is from PTC Therapeutics. He's going to be talking about Emflaza. I think you know that we sort of randomly mix those two from deflazacort to Emflaza. Emflaza is the US approved product, which was formerly known when we all got it from Europe as deflazacort.
Thank you. I appreciate it. Appreciate the opportunity to be here. I've spoken to a lot of different groups, both internationally in the US, and by far I have to say you guys terrify me the most. And part of that is just because, living with DMD and going through the journey and seeing what you guys go through and really getting a feel for the lives that you have and seeing how you guys have redefined DMD, that it's not defining who you are, but you're redefining it. The kids that I see here, the families I see here is great. When I talk to clinicians, it's very clinical, it's very, I think anesthetic in some ways. With you guys, it's very emotional, it's very heartfelt. And again, I just want to say to you, thank you. Now, that's not the end of my presentation. I know we're trying to get back on track. It's not the end, but I think the most important thing is this is about you. This meeting is for you. This meeting is for you guys to come together, to hear different information, for you guys to be part of this community. And I know Pat's done a great job of helping me kind of become part of the community as well. Where I work at PTC, we have a saying that it's the patient, and that's what we're doing. This is why we get up every day. And I have to say, getting to know some of the families, getting to see the families, getting to be part of this, it helps us to get up and to get moving and to look for better treatment options. So just a quick background on PTC. It's a very unique place because the founder who started the company is actually the current CEO, and he's here in the audience today. So, if you know Stu, you love Stu. He's got a heart of gold, and I think that passion for what he does has trickled down into the entire culture of PTC. One of the things that we look at doing is we're looking at trying to give a voice to a lot of patients and give patients treatment options that didn't exist. So, we're in areas such as, multiple genetic disorders, DMD, in dystrophinopathies in general. I think Pat had mentioned it yesterday, looking at dystrophinopathies, not just one particular type. So limb-girdle 2I, which is a type of dystrophinopathy, we're looking at that as well, and then looking at SMA. Gene therapies for AADC deficiency. So when I look at the group, when I look at the audience, and I think about our pipeline, basically we have in our pipeline 17 groups of you. So each of the groups, each of the disease states that we focus on, each of the compounds that we work on developing every day are representative of groups of people like you, families like you. And I say in DMD, we don't treat the patient, we don't treat DMD, but we treat the family. There you go, I'll say. So, we have multiple different things we're working on. As I mentioned, gene therapy, Emflaza, what we'll talk about mostly today, Translarna, Tegsedi. So there's a lot of things in the pipeline, alternate splicing therapies and oncologies. I think it's a great opportunity for us. I think it's a great opportunity for the DMD community, what we're trying to do. So you guys have all heard of steroids. Does anybody by a show of hands know how steroids work? All right, I guess I'm on my own. So I'll tell you how steroids work. But the big thing I think I wanted to highlight here is we know steroids have a benefit in DMD. We know that they do prolong function, and so you see less decline. The velocity of decline, as was mentioned before, is slower when patients are on steroids. And the loss of ambulation is one that we look at a lot, and it's also prolonged, so kids tend to walk longer. We understand that loss of ambulation is not the end-all, be-all of the disease in the situation, but we understand that that's a marker, that's a very important, transition point for families. We also then understand what comes after that. So we'll get into a little bit more of parsing this out to really understand how steroids are working in DMD and why they're working. So this is your muscle. This is your child's muscle. So in typical normal fashion, if a muscle is functioning the way it should, if there's injury that occurs to it, then the muscle will become inflamed, there'll be an inflammatory response, and then that'll trigger a regenerative process. So the muscle will heal itself, get better. But what we see really in DMD is we're stuck in this inflammatory phase. We're not really regenerating the muscle, it's not getting better. So over time, that's where you see the fibrosis come into play. The constant inflammation will lead downstream to fibrosis. So what we're trying to understand about this, and I got excited earlier because we were talking about the immune system when we were talking about gene therapy, it was more viral vectors. I want to reintroduce the idea of the immune system with regard to what's happening in DMD. So what we're seeing here is there's certain signals and there's certain regulatory benefits that occur within the body. So as inflammation occurs, then there's signals that are sent out to regenerate that. But in DMD, it looks more like this. So if you think about that, up at the top, you've got your dystrophin deficient muscle. So it's kind of got this leaky membrane. You've got some stuff coming out. So while we're trying to fix the dystrophin deficient muscle, while we're trying to replace dystrophin, we have to think about how do we spare what we have? How do we maintain the muscle that we do already have? So when this muscle membrane is leaking out the contents of what's in the muscle, it actually acts as an antigen. So the immune system sees this and says, hey, we don't really produce this. We don't have much of this. This looks like a foreign invader. So what happens is the immune system, it's circulating on a regular basis, kind of just floating around looking for things that shouldn't be there. It identifies the bits of the muscle, the dystrophin, as a foreign entity and wants to get rid of it. So then as you see kind of down past the second little area, the innate immune activation, you get into more of an adaptive immune activation. So as the immune system is doing what it's supposed to be doing, as the inflammation is cleaning up, the issue, as the macrophages are cleaning up the inflammation, it's presenting it back to the immune system saying, this is the thing that you want to target. So as kids get older, this immune response gets worse. And so this is why then you see, overall, we have to deal not only with the dystrophin production, but we have to look at dystrophin sparing, and we can do that via the immune system. So a lot of times the question comes up, aren't all steroids the same? So all DMD drugs aren't the same? Because again, now we're starting to get into two classes of drug. One is dystrophin producing, and one is dystrophin sparing. So the idea is, are all steroids the same? The answer is no. I'll give you the hint just because we're kind of low on time. But when we look at Emflaza, and we really want to understand how Emflaza is working, because the whole primary reason Emflaza has been used is because the benefits, the effectiveness, the long-term outcomes for the kids have been better. So what our team has done, we've got a team of clinicians and scientists. We've read, I think, at least 800 articles, maybe a few more, to really understand what's happening, to really dig deeply into this, because this will give us keys to future evolution of drugs and treatments. So Emflaza, as you know, is indicated for DMD for ages 2 and older. The drugs, at the backbone of the drugs, they look similar, but when we change functional components of the chemical structure, the drug is going to act differently. And we hope it acts differently, because there's certain things that we like about what prednisone had done. There's certain things we don't like about what prednisone has done. So we're trying to improve upon that with the generation and creation of deflazacort in Emflaza. We're looking at a better way of doing things. So because these look different, because they're structurally different, they're going to be functionally different. And so going back to the immune system. So as I mentioned before, that slide that showed the dystrophin muscle and leaking in and the immune response, what we look at is we want to understand, does Emflaza do something different to the immune system that prednisone does not? So this is a study from Kevin Flanagan and his group at Nationwide. And what they had the exact same question, because they noticed there was a specific anti-dystrophin T cell response. So they wanted to understand, in these kids who had this immune response to dystrophin, did it make a difference which steroid they were on? Did it differentially control it? So what he found is the kids on deflazacort had much, much lower immune response to dystrophin. So this suggests to us that with the T cells being controlled differently, that there may be a different outcome when we see it in clinical outcomes. So what this means too, so if I look at interferon gamma, so that was the way that Kevin and his group had measured the immune response. When I look at interferon gamma, and if I can downregulate interferon gamma, it's going to change the signaling that occurs within the patient. So as the previous speaker had talked about NF-kappa B, and you can kind of see it on the, I guess, the left side of the diagram. What we look at is say, if we can interrupt the cascade earlier, if we can stop this sooner, do we see a benefit? Do we hit more targets? Because if we just look at NF-kappa B, while it is a good target, it's not the only target, because we leave also then the JAK-STAT pathway uncovered. So we look at this and we understand that Emflaza is really differentially controlling interferon gamma, which is resulting in this additional benefit for the kids as compared to prednisone. So the question always is, am I sure? Pretty sure, I think. How do I know? Well, that's the good part. We've done our research, we've done our homework. What side effects can I expect? Always a good question. Okay, show me. I get it. You guys want to see it? Proof is in the pudding. Tough crowd, totally understand. So when we look at clinical trials, and we had talked about this before, I think yesterday, they had brought up the different endpoints, and they looked at the different measures, and they looked at the different subjective versus objective. I mean, there were about 50 different measures you could do, and North Star had a lot of different things. What we've seen consistently with Emflaza is no matter how we measure it, no matter how we design the trial, no matter how we do the studies, or anyone else does the studies, we're seeing the same outcome. We're seeing this difference between Emflaza and prednisone being superior, for Emflaza. So in this study, they looked at, this is kind of a more contemporary study, because Emflaza has been studied for quite a while. This is a more contemporary study, so it's looking at patients in more of a modern setting, looking at things like 6-minute walk distance, looking at 10-meter walk run, 4-stair descent, those type of things. So when we look at what we see in this controlled trial, multi-center, what we're really seeing here is that the kids over time, and this was over 48 weeks, the kids on deflazacort or Emflaza ended up losing less distance. So their velocity of decline was slowed by the use of Emflaza as compared to prednisone. So in this case, deflazacort patients lost 39 meters versus the prednisone group lost almost 71 meters. So when you look at those are statistically different outcomes. So what that means is not just by chance. It wasn't just a flip of the coin. It wasn't just some random occurrence. But we know statistically the drugs are different. And that outcome is meaningful because when we look at the other outcomes and we look at the other measures of the study, across the board, every one of the measures was showing a benefit towards deflazacort. So when we're asking, to what extent if we, any way we measure, if we look at loss of ambulation, POTS sports, if we look at multiple different ways, we're still seeing the same outcome. No matter how we cut no matter how we cut the deck, we're seeing it the same way. So when we go back to the 6-minute walk distance and why this becomes important, as a clinician, we can look at the 6-minute walk distance and we can project out at what point in time would we lose ambulation. So again, looking at this, the difference between those two is about 3.8 years. I think 3.84 technically is what it is in the publications, but this gives you an idea that the kids are walking longer. So when we look at the benefit and we look at the side effects, one of the things is that we're seeing much longer ambulation, we're seeing much longer benefit for the kids with Emflaza, but it doesn't come at a huge cost in reference to comparing it to prednisone. So we're still seeing side effects, and I think as it was mentioned earlier today, to see a drug that has an effect that has no side effects or a drug with no side effects, it typically does not happen. Usually all drugs have some type of side effect if they're working, if they're doing what they're supposed to be doing. But when we look at the comparison, we're seeing this increase in clinical efficacy and effectiveness for the kids on Emflaza, but not at a huge cost with huge increases in side effects as compared to prednisone. So when we look at the synergy study, so we're going to look at this longer term, because I think the important thing to understand and to look at is in the kids, in your families, you don't have just a 10-week issue to deal with DMD. You don't have a 1 year. This is a lifetime type of situation. So in clinical trials, and I think what becomes incredibly difficult within DMD is to get a full impact and get a full understanding of what the benefit of the drugs are. You have to look at this over a longer period of time. So Synergy it's a real world study. And it was designed to look at patients, what they were on, whether it was on daily deflazacort, whether it was on low-dose intermittent prednisone, high dose, 2 days per week prednisone, or looking at daily prednisone. They wanted to understand in the real world how I dose this, how the families dose the drug, how the clinicians prescribe it, what happens. If we can follow them for 10 years, if we can look at these kids for 10 years, look at these families and understand what's happening through the course of time and understand what clinical benefit each drug offers, then we can get closer to understanding this disease state. We can get much, much better, get much more precise in what we're doing. And so what they found in the synergy data, when they looked at this was a particular analysis that was done in 2015 by Bello. And what they saw in that is that there was a statistical difference, again, with the daily deflazacort allowing kids to walk longer. So loss of ambulation was significantly delayed. In this case, it was delayed by 3 years. And when you looked at the prednisone doses, no matter how you dosed it, whether it was high dose weekends, whether it was alternate dosing, whether it was daily dosing, none of those doses were equivalent to what you saw with daily deflazacort. All of these being statistically significantly better in favor of deflazacort. So this is important because I think the big thing I see within Duchenne is you guys are a very empowered group. You know, hearing the questions that were asked throughout the course of this meeting, it's very refreshing to see how much you guys have invested in understanding what's going on with your children and really understanding what the impact is. So I think it's important, you know, that you guys have the information necessary to make informed decisions to be part of that treatment plan. Because again, like I said before, we're not treating just Duchenne, we're treating families. And so it's important that everybody has that information. So when we looked at this across different measurements as well, what stood out, and you can see them in red there, is the measurements that we can do with our eyes. So as non-clinicians, if there's non-clinicians in the audience, non-clinicians can do these measurements with their eyes because these are binary events. Either I can do it or I can't. So when we look at this, and the things that I think are important is, can I stand? Can my child stand? Yes or no? And what you saw is the kids could stand significantly later on Emflaza as compared to prednisone. And then when you look at the loss of ambulation again and say, can the kids still ambulate? Again, it was significantly longer for the kids on Emflaza as compared to prednisone. And then the same thing too, the loss of hand-to-mouth function. What you saw, it was much longer again, 2.7 years in that regard in favor of Emflaza. So the things that we see as families and as parents, the things that matters for our kids, I think it's interesting that these things stood out as, again, being not just by chance, but these things actually, there's a benefit for these kids on Emflaza throughout the course of the trial. So across the board, what we're seeing, and just like in the other slide, in each of the groups, we're seeing a benefit for Emflaza. So each of the measurements, we're seeing a benefit for Emflaza. Those ones in red particularly, I think, stand out because they're easiest for us to measure. It takes out some of the subjectivity of, did I start the stopwatch at the right time, and how far did the kid walk? So we're encouraged by that. And again, looking at side effects, when we see this in a larger trial over a long period of time, we're not seeing this huge cost of additional side effects in exchange for the benefit in the clinical outcome for the child, which is encouraging, especially as I'm modifying the immune system, as I'm allowing the immune system to let the dystrophin that I do have exist and cohabitate with the rest of my body and to regenerate muscle to some extent. I'm seeing this and I'm not paying a huge price for it. And so what's interesting is if you go back to the olden days, so this was the study that was done quite a while ago. It's the first study that's in the label. When you looked at it's kind of, it'll make you laugh a little bit when you see the other ones. So we looked at 48 weeks, we looked at 10-year studies. When we look at some of these studies, it was a 12-week study. So back in the day, the whole idea with steroids, back in the day is people didn't think steroids actually had a benefit in Duchenne. So the original studies that were done were done to prove that the steroids did not have an effect, and actually they found that prednisone had an effect. So then when we're looking at these other studies, we're kind of mimicking what had been done in the past. We're looking at kind of short-term studies, but then we also have a long-term piece as well, because truly to get a feel for what's happening with the kids, we have to look at this over a longer period of time. So even back in the day with a study that was designed appropriate for the time, but we wouldn't do it the same way today, we did see this signal for this long-term benefit. So when you look at this, and you can see that the different, you've got the different bars, the deflazacort as it's dosed, on the market now, and prednisone. When you look at these, you see some similarities in the beginning, But the thing is, over time, you see this bigger separation because the kids are changing. You see this long-term effectiveness that's really beginning to be established at this point in time, which is a signal to us to look at this longer. So everything that we've learned from trials in the past tell us that sometimes it's difficult to do the same trial twice, and sometimes we have to understand what we're looking for to adequately see the benefit. So when we go back and when you put that in a much bigger picture of what you're seeing for these kids, again, I'm seeing this long-term benefit and I'm not paying the price with a huge side effect burden from the standpoint of it's not greater than what you would see with a prednisone dose. So I think that's encouraging to us. We saw less weight gain and less cushingoid appearance in those trials as well, I think, which is encouraging because I know that those things are issues to deal with. So overall, no matter how we've cut the data, no matter how we've looked at the studies, when we control inflammation, when we change the downstream regulation of cytokines, and when we change the downstream process by which patients are losing muscle, we see this long-term effectiveness for the kids. And no matter what type of study we do, whether it's an open label, prospective study, whether we do a standard of care comparison in a randomized control trial, or whether we do a RCT straightforward, we see the same benefits, we see the same outcomes. So in general, that's kind of what I have for you. I appreciate your time. I appreciate your opportunity to be in front of you guys. I appreciate any questions you have later as well. So thank you very much.
Thanks, Brian. Now, is Paolo here? Yeah, there you are. Okay. Paolo's from Italfarmaco, and they have a drug in trial as well. So we're going to hear from Paolo to talk about that study and what they're learning.
Thanks, Pat, and thanks to you all for the invitation to actually update you on where we are in the development of givinostat. So my disclaimer is actually short because we are not on the stock exchange. So I'm actually a full-time employee of Italfarmaco, which is a manufacturer of givinostat. Givinostat is currently in development, so it's not available on the market in any country around the world. And this presentation is intended for dissemination and discussion of scientific information only. So this is what I would like to show you today. So first of all, what is the role of givinostat in DMD? Secondly, take you on a brief review of the clinical data that we have, and in particular to give you an update on what I've shown already last year, so one more year of data, and then tell you where we are in the phase 3 study. So this is to try and understand how givinostat works in Duchenne. And I think before talking about givinostat, it's important to understand what is the role of the HDAC, because givinostat is actually an HDAC inhibitor. What is the role of the HDAC in Duchenne? And as you can see in this cartoon, it plays quite an important role in Duchenne. If you think first, if you look first at the bottom part of the slide, there you see what is the role of the HDAC within the muscle cells. And in essence, the HDAC are under the control of dystrophin and of the dystrophin complex. And when dystrophin is not there, as is the case for Duchenne, in essence, the HDAC are overworking. And as they overwork, what they do, they actually reduce the translation of muscle regeneration factors. So they actually play a significant role in the, if you're an impairment of regeneration that we see in Duchenne. The other thing is when you actually miss dystrophin, as we have heard many times during the meeting, you have obviously an instability of the membrane and a damage of the muscle cells. And this actually determines the release of a number of factors that actually stimulate the immune system. So they stimulate inflammation, and at the end of the day, they actually end up in generating fibrosis. And also here, actually, the HDAC are playing an important role, and that has been shown in many, many studies. So if we think about what givinostat does, in essence, is inhibiting the HDAC within the muscle cells. So as a result of that, is actually increasing the translation of muscle regeneration factors. And also is acting on what happens outside the muscle cells, so the inflammation and fibrosis by reducing both of them. And actually, we have shown that in the mouse first, but also in the human being, as you will see in a second. So if we put all this together, in essence, the idea is that givinostat can actually restore the balance and actually, by reducing the fibrosis, necrosis, and inflammation, and by actually increasing the regeneration of the muscle fibers. So then, what is the situation? So, which is the summary, if you want, of our clinical data so far? So, we have been conducting a phase 2 study and its extension for quite a long time. As you can see there, we started in May 2013 by enrolling 20 Duchenne boys. They were 7 to 11 at that time. They were ambulant and they were on stable steroids. And the first part was to identify the best dose to be given to these boys. And then they were treated for 1 consecutive year with that dose. And at the beginning of the study, we collected a muscle biopsy, and then we performed a second biopsy after 1 year of treatment. And then the kids that completed the study and wanted to continue, they were actually allowed to continue in an extension. And then, as you can see, 1 extension became extension 2 and then extension 3. And now, actually, in November 2017, we closed the study, study 43, but we open an open-label study, which is study 51, where, in essence, all patients that have been treated in a clinical trial will go to up to, hopefully, the marketing approval of the drug. So as a result of that, we now have data on more than 5 years of treatment with givinostat. And as you can see, the age of the kids when we, if you locked the study 43, was actually close to 14.5 years in total. And as you can see, we started with 20. We are now at 16 kids. 3 of them actually dropped out, none for tolerability reasons. Okay, this was what I've shown many times before and what is actually published already, which is that the primary endpoint of the study of the first part was actually to look at what happens in the muscle with givinostat. And as you can see, we see an increase in muscle fiber area fraction. And by the way, each column is one child, and the black column is the mean of the result. A reduction of total fibrosis, a reduction of total necrosis, and a reduction of fatty replacement. So in essence, confirming within a muscle biopsy what I was describing at the beginning. And obviously, all these results were highly significant. So as mentioned before, obviously, we now have a follow-up of more than 5 years on treatment with givinostat on top of stable steroids. And we can look at important milestones of the disease. And the first one is obviously to look at what happens in terms of loss of ambulation. The study by Craig McDonald and the Synergy Group has been cited different times today. And this is just to remind you that obviously what the study showed was that the treatment with glucocorticoids was actually prolonging the time of ambulation, so delaying the loss of ambulation significantly. And the median age of loss of ambulation in that study was 13.4 years. So we actually applied the same approach to look at what happens if we actually add givinostat on top of steroids. And last year I presented some initial data, and obviously at that time I was saying we continue to follow up the kids, and so the more data that we have, the more precise we will be in understanding what the loss of the delay in loss of ambulation might be. And this is a situation as of the end of 2018. So the median age is actually 15.1 years. So suggesting a significant delay in the age of loss of ambulation. Then what we can also do is actually look at another parameter, which is actually the respiratory function of the drug. Because obviously the kids are becoming older, and so this parameter is becoming quite important. And as you know, and because it has been mentioned many times today, based on the natural history data, we are expecting between 4 and 6% delay every year of the two parameters that you see there, the FVC, so the forced vital capacity percentage predicted, and the peak expiratory flow. And as you can see here, these are the, if you're on Givinostat results, for the FVC percentage predicted is actually 2% yearly decline, so less than 50% of what is in the natural history. And actually for PEF, there is no decline, so it's a stable parameter. In terms of safety data, actually the picture has not changed to what we knew before actually running the study. So we know that actually Givinostat has some adverse events. One is diarrhea, which is, as you can see, frequent, but actually has never been a reason for stopping the drug. So it's actually usually mild and manageable. And the other one is actually the reduction of platelets. So we know that this is a pharmacological effect of the HDAC. They actually freeze the maturation of platelets, which means that the finding is actually seen quite early, within usually the first or second months of treatment, if the dose is too high. And then also, when you stop the drug, actually the platelets go back to normal within 1 month. So also this is actually a manageable adverse event that we have learned how to deal with this experience. So this is really a summary of the data that we have collected. As I mentioned at the beginning, we have shown the histological effect of the drug in the muscle biopsy. I actually showed a couple of years ago the MRI data that were supporting also the histological effect. And the recent data support a potential delay in the disease milestone and in the respiratory impairment. Okay, so now the update on the phase 3 study. This is the design of the study. So the objective is to demonstrate that actually Givinostat preserves the muscle mass and slows down the disease progression. And this will be done by evaluating the functional test. The Forster climb is actually the primary endpoint, but also by looking at the morphological effects by quantitative MRI. It's a double-blind placebo-controlled study. We are randomizing 2 to 1, so 66% of the boys in the study will take Givinostat and 33% will take placebo. It's an 18-month treatment study, so they will be treated for 18 months, and they will undergo an MRI at baseline after 12 months and after 18 months. And then all patients that want and have completed the study and want to continue treatment, they will actually move to the study 51, which I mentioned before, which is our open label study, which is already open. This is what, in essence, the participant will have to do. Obviously, the informed consent at the beginning. They will actually have 15 visits at the site. From the third month is actually every 3 months. The first 3 months are more intensive because, as I mentioned before, we need to proper define the dose to be used in the single subject. As you can look at the top right, Givinostat is actually a suspension, so the kids take it at home in the morning and at dinner, and it's usually taken with food because it's slightly bitter, so it's actually better to take it with food. And every 3 months we have the standard functional test, so 6-minute walk test, North Star, Forster climb. We measure strength. And then the pulmonary function is actually measured at the beginning, then at 12 and 18 months. And as I said before, when the kids complete the study, they can actually switch to study 51, where obviously they will all receive the drug. There is no placebo in study 51. These are the inclusion criteria. So we are allowing into the study kids that are 6 years and older, that they can walk. Obviously, because of the way the drug works, any genetic defect will be allowed. They need to climb the stairs in no more than 8 seconds, and they need actually to rise from the floor in no less than 3 seconds and less than 10 seconds. And they have to be on stable steroids for at least 6 months. They will perform a baseline MRI, so they should not be claustrophobic or have, if you want, exclusion for the MRI. And the key exclusion criteria are actually listed there. So obviously, if they have been on other investigational drug, they are either excluded or they have to go through a washout period. Contractures we are controlling because obviously this is important in the Forster climb. If they plan to have surgery, they would not be allowed. And obviously the heart needs to be sufficiently healthy, so the ejection fraction needs to be more than 50%. We know that actually the frequent visit to the site at the beginning and then the visit to the MRI will cause also a significant cost. So we have a system to actually reimburse all the traveling. And also for the initial part of the study, we have actually nurses that will come to your home for the sampling. This is where the study is. So it's North America, Canada, and US, and then in Europe. As you can see, Spain, France, Italy, Germany, Holland and Benelux, and UK. Actually, the number is wrong because today is 103, luckily. And we are actually looking at the moment at potentially opening new sites both in the US and in other countries. And this is really to thank all the, obviously, all the families and the kids that have helped us in the study, all the different organizations we have been working with. And importantly, you can find all the details on clinicaltrials.gov. But also, as you can see there, we have a patient advocacy person that is Anna Christensen. And you can actually either phone her or email to her for any question you might have. Thank you.
Thanks, Paolo. So now Paula Clemmons is going to talk about ReveraGen's drug, valmorolone. And Paula was at our conference number 2, 24 years ago.
And unfortunately, John Finder has a picture of me a few years later where he very nicely says, I don't look any different. Yeah. So thank you very much. I am Paula Clemmons. I'm a professor of neurology at the University of Pittsburgh. I'm a neuromuscular neurologist who's focused my career on muscular dystrophies with a primary focus on Duchenne. And also the medical director for the Synergy Clinical Research Group, which is a multi-center academic research group that has focused on doing multi-center studies in Duchenne. Do I advance the slides? This one here. Okay. So I am speaking on the part of ReveraGen, which is a spin-off company of academics that was developed to further develop this vamorolone drug, which is a novel anti-inflammatory drug. And so in panel A there, we compare the structure, the chemical structure of vamorolone with prednisone And you can see that it shares the steroid ring structure that all steroid compounds do. But very importantly, vamorolone, unlike prednisone or deflazacort, is not a glucocorticoid. And there's a key double bond in the middle of that ring structure that makes that difference. And it creates a kink in the model, which is shown in the molecule, which is shown in the B section of that, where prednisone is shown in blue and vamorolone is shown in red. And you can see that it bends in a little bit of a different way, which means that then it binds in a different way to the glucocorticoid response element. It binds differently to coactivators and co-repressors, and it has a distinct difference then in the way that it behaves. And the reason that it's being developed through clinical trial development is that preclinical studies showed that it preserved the anti-inflammatory effects of glucocorticoids, but as a novel steroid, it seemed to lack some of the side effects that are associated with that. So the first set of studies that were done on vamorolone after the preclinical phase and after it was tested in healthy controls were the phase 2A studies. And this was an open label dose escalation phase. So there were 4 dose groups, starting with a low dose group of 0.25 milligrams per kilogram, and each dose group tripling the dose level up to the top dose level of 6 milligrams per kilogram per day. This is an oral drug. It's taken as a liquid suspension once a day. So the first part of this study was that each dose group was treated at their dose level for a 6-month period. And as each of the lowest doses showed safety, then the trial went on to the next dose level and on and up until the highest dose level with 12 participants in each dose level, so a total of 48 participants. And at the end of the 6 months, the participants had the opportunity to enroll in what was called the long-term extension. And that study is ongoing at this time. The 002-003 phase is completed, so all patients are either in the long-term extension or have finished the long-term extension and have joined the expanded access program, which is a typical expanded access program that has diminished burden in terms of sort of clinical trial style collection of endpoints, but provides for access to the drug. In the next slide, what I'm going to tell you about is that long-term extension, because one of the unique features of the long-term extension was that, or has been that it allows for a dose escalation of those participants that started at the lower doses. And this multicolored diagram explains that to you. And this here, I would be greatly helped by a pointer, so I'll try and talk you through it with the colors. If you start at, what this is showing sort of the longitudinal dosing going from left to right. So the bottom bar is the lowest dose group that started at 0.25 milligrams per kilogram. They did the first 6 months at that dose and then entered the long-term extension. And when the next dose group, which started in green there, when that proved safe, then the participants in the lowest dose group could move up to the next level, the 0.75 or the green level. And once the green group was done, then the blue group started at 2 milligrams per kilogram, and so on. And so what you can see is that all participants that stayed in the long-term extension accelerated their, or escalated their dose to either 2 or 6 milligrams per kilogram. The top group that started at 6 milligrams per kilogram, all participants have stayed on that same dose for the full long-term extension. Now, the 2 top doses, typical for clinical trials is that you start at a very, very low dose that you really don't expect is going to be efficacious, but you do that in the interest of safety because you want to first prove when you're starting to test a drug that it is safe. And hence for this design that it could escalate so that those who started at the lower doses would have an opportunity to get to the higher doses. But what this dose escalation design allows you to look at serial safety, and there was no safety issues that led to drug discontinuation. So at all 4 levels of dosing, the drug appeared safe. And in some of I will show you some of the data in subsequent slides, but essentially the 2 and 6 milligram per kilogram dosing appeared to show efficacy. And we've had a few patients in the study went up to the 6 milligram per kilogram dose and decided to move back to the 2 milligram per kilogram dose, and I'll talk a little bit more about that. So this slide shows the primary outcome measure for the primary efficacy outcome measure, which is the time to stand from the floor. And the left panel is the 2 milligram per kilogram group, and the right panel is the 6 milligram per kilogram group. This is commonly called a spaghetti plot. So each colored line reflects a single participant. And on the y-axis, you're looking at the time in seconds that it takes to stand from the floor. And the x-axis is as you're moving through the study. So this data ends at the 12-month time point for the long-term extension study. And remember, all of those participants had 6 months on drug prior to that, so it's an 18-month total exposure to drug. So really the point from this slide is that the time to stand is really preserved with the exception of a single participant in the highest dose group that started with a time to stand of 14 seconds, so in sort of the higher range. So this shows the results in a little bit of different format, and let me walk you through this. So each of the different colors represents the different dose groups. So dose group 1 was the ones that started at 0.25 milligrams per kilogram, ultimately dose escalated. The green group is the 0.75 milligrams per kilogram, blue is 2 milligrams per kilogram, and the red is the 6 milligrams per kilogram. So, and it's important to realize when you look at this slide that the orange and the green groups, because they had to start at the lower doses, they've had less amount of time on what we think is an efficacious dose of 2 or 6 than have the 2 highest groups, the blue group and the red group. Now, several previous presenters have mentioned an important study published out of the Synergy Duchenne Natural History Study published by McDonald et al. In Lancet in 2018. And this identified a series of Duchenne functional milestone groups. And the first 3 groups were based on a time to stand. So the best function is a group 1 with a time to stand of less than 5 seconds. Group 2 is between 5 and 10 seconds, and group 3 is a time to stand greater than 10 seconds. And so what we're showing in this graph is where the groups stood in terms of those milestone groups between baseline and 18 months. So in those 2 higher dose groups, the 2 milligram per kilogram and the 6 milligram per kilogram, you can see that there is an apparent improvement actually in milestone group over the 18 months of treatment. And shown in a slightly different way is in these graphs. So here we're plotting the time to stand in seconds for the participants in the 2 and 6 milligram per kilogram dose group. Remember, again, these are the ones that had gotten 18 months of treatment at either 2 or 6 milligrams per kilogram. Each dot represents a participant, and now they're plotted based on their age. So the top plot is their age at baseline, and it shows what their milestone group is. Or it shows their seconds, so that 5-second threshold for time to stand is really the threshold for the first milestone group. And the bottom plot shows the same group of participants now at of course, an advanced age, because this is at the 18-month visit. And if you look at this, if you take all comers and look at it statistically, there is a statistical improvement, but clearly no decline over the course of the study. So moving to looking at some of the safety outcomes, body mass index was the primary safety outcome. And again, these are these spaghetti plots where every colored line is a participant in the study. The left plot is the 2 milligram per kilogram cohort. The right plot is the 6 milligram per kilogram cohort. And you can see that a couple of individuals in each of these groups have had weight gain that we customarily see with the glucocorticoids, but the majority have not. And this is something we're continuing to watch closely. And these were the situation. These were generally the participants in the study that elected to decline from 6 milligrams per kilogram to 2 milligrams per kilogram. And we're continuing to follow them to see what happens with regard to weight gain over the course of the study. So this slide is looking at physician reports of cushingoid appearance and weight gain in the long-term extension study. And what it's comparing it to is a published study of placebo, deflazacort, and prednisone that was published by Birch Griggs in 2016. And effectively, the take-home message here is that we're really seeing essentially no report of participants having a cushingoid, or very, very few reports of them having a cushingoid appearance. And the weight increase is really limited to a few of the subjects. And another key concern with glucocorticoids is stunting of growth. To date, in the long-term extension, in the high doses of vamorolone, we are not seeing a stunting of linear growth. So this takes a step back to look at the entire program. So what I've talked to you about so far are the phase 2A group of studies. What began in the latter part of 2018 was a phase 2B study. And this is the pivotal study, which is a placebo-controlled randomized study to compare vamorolone to placebo and also to prednisone. And also you can see on this slide that there are plans underway to expand the age group both to younger and to older for testing of vamorolone. So very briefly, the pivotal study design is again in the age 4 to less than 7, steroid-naive Duchenne. And this will have a first 6-month period called treatment period 1, in which participants will be randomized into one of 4 arms, either 2 milligrams per kilogram of vamorolone, 6 milligrams per kilogram of vamorolone, prednisone, or placebo. And then after that first 6 months, the placebo and prednisone participants will be randomized into the 2 milligram per kilogram or the 6 milligram per kilogram group during treatment period 2. And these randomization schemes will be set up at the start of the study, so the study will remain completely blinded through the full year of the study. And at the end of the study, participants will have an opportunity to either taper off if that's what they choose, or to enter the expanded access protocol. So this is a very large study. The plan is to enroll 120 participants, 30 in each of the 4 arms. And so this lists the North American sites in both the US and Canada. Shown in blue are the phase 2A synergy sites, the sites that participated in the phase 2A and will also be participating in the phase 2B. Not in blue are the sites that are being added for the phase 2B. And the study management for this is done by the TRINS, which is a neuromuscular specialized CRO for study management. And this slide shows the sites in Europe, Israel, and Australia. And again, the sites that participated in the phase 2A studies are highlighted in blue. So I want to acknowledge a number of folks that have been important in this. There are the study participants and their families, which are just critical to moving research forward. My study chair responsibilities are shared by a colleague, Michaela Guglieri, and certainly want to acknowledge the entire Synergy Network, plus all the new sites in the phase 2B or 004 study. Trial management by the TRINS group with additional help in medical and clinical monitoring, and also want to shout out to the Synergy Data Safety Monitoring Board, which is a group of independent group that really provides a tremendous service. The ReveraGen development team is a group of scientists who have developed vamorolone and continue to test it and work on formulation, et cetera. Suzanne Gaglianone is here at the meeting. She is a Duchenne mom, and she does all the travel arrangements for participants in this study. And she's here at the ReveraGen booth at this meeting. I really want to acknowledge the financial support, which has been tremendous for this whole program, both from the US government and a large European Commission grant. And also importantly, that this is being operated in what's called venture philanthropy, which means that rather than stockholders, there are stakeholders. So there's this whole group of a dozen Duchenne groups that have contributed at various steps along the way to the development of this, as well as a tremendous amount of support from the NIH and from the European Commission grant. So I'll close in summary. So vamorolone's an investigational drug, shows dose-dependent efficacy in Duchenne in the open label study. And this preliminary evidence show improvements in gross motor function tests. And although this was an open label and not placebo-controlled, we don't show benefits not shown at the lower doses and is shown at the higher doses. So that's at least suggestive, despite its open label nature, that it is interesting benefit. No participants left the trial because of safety concerns, and there's a fair amount of high-dose drug exposure at this point. And most importantly is really a critical juncture of needing to enroll the double-blind study. This is a pivotal study that's required before there would be the possibility of getting regulatory approval either in Europe or in the US. It's really critical. There is a placebo and prednisone arms, but they're only for the first 6 months of the trial. And I will stop there. Thank you very much.
Thank you, Paula. Our next speaker is from Mallinckrodt. Jacqueline? Oh, there you are. Okay. Good. So Jacqueline's going to talk about Mallinckrodt's MNK 1411. And I didn't say your last name because I think I'd mess it up.
Jacqueline Delfgaauw. It's a little hard. Fits nicely with Mallinckrodt, which is also a tough name, no? First of all, I would like to thank Pat and PPMD for organizing this meeting and giving all of us this great opportunity to interact so directly. And then thank you to all of you who are still here in the room that late on a Friday. We really, really appreciate it. So you might have seen in your bag and might have also wondered what this material is. So I will be now the one talking about this study. You heard it as BRAVE. You saw it, as I said, maybe all the material in your bag. I will be first explaining our compound. It's also an investigational drug. We don't have a fancy name yet. We still call it MNK 1411, as Pat also just said. So let me first explain what that compound is before I then go into our phase 2 trial. First, of course, also from my side, a quick disclaimer. As I said, it's an investigational drug, so I'm here to educate us all on this compound and the study. So MNK 1411 is a melanocortin receptor agonist. Sounds fancy. So the question is, what are melanocortin receptors? They are also called MCRs. You heard a lot here about scientific mechanisms and so forth. I think we have not yet really heard about melanocortin receptors, so I think it's worthwhile spending a few minutes on that. So melanocortin receptors are a family of G-protein-coupled receptors that bind melanocyte-stimulating hormones and adrenocorticotropic hormone. There are 5 known MCR subtypes, each with a distinct distribution throughout the body. And to make it a little more visual, here they are. So we have these 5 subtypes. They are just simply called MC1R up to MC5R. And you see on the right side the cellular expression. So if we just, for example, look at MC1R, it's expressed in leukocytes, central nervous system cells, kidney cells, muscle cells, very important, many other cells as well. MC2R, adrenaline cortical cells. MC3 again is expressed like MC1R, and MC4R is only expressed in CNS cells, and number 5 in leukocytes again. What that means, I will talk about that in a second, but first of all, what is an agonist? We have not talked about that yet. So a receptor agonist is a substance which binds to receptors and causes thereby receptor activation. So as I just mentioned, MNK-1411 has been reported to activate all these 5 known melanocortin receptors to generate certain biological responses. So again, here the cellular expression that I already showed, and now on the right side, the functions that we believe that we could show that the receptor activation by MNK-1411, what it does pretty much. So again, if we just look at MC1R, for example, MNK-1411 here seems to reduce the inflammation. So again, also in our fact, we heard a lot about anti-inflammatory drugs. Now also here we have anti-inflammatory activation. It also has an effect on how the immune system responds. I'm jumping now to 3 because I come back to number 2. Also here, reduces inflammation, modulates the kidney function, for example. Our subtype 4, there MNK-1411 seems to also reduce inflammation, but also preserves the neural structures and or their functions. And for number 5, we seem to have an immunoregulatory effect, which is also super important. Let me now jump back to number 2, and you see it's a little bit in a different color. Here we seem to have the effect of MNK-1411, that it forms the formation of steroids, and I will come to that in a second. I just want to point out MNK-1411 seems to have, besides a lot of other function, also steroidal effects, but it's not a steroid. That's very important for us to point out. So I talked about now how it binds, what it seems to be doing, but what is MNK-1411? So the active ingredient in our compound is a man-made shortened form of the natural hormone corticotropin. So corticotropin is also called short abbreviated ACTH. I'm pretty sure you have heard about it. Ours is a man-made shorter version. Products in this class of ACTH have been initially developed because it was known that they stimulate the production of cortisol, and cortisol was thought to have anti-inflammatory effects. When the receptor mediating the effects of ACTH in the adrenal gland were identified, 4 related receptors were discovered that also can respond to ACTH, the family of the melanocortin receptors that I just introduced. Melanocortin receptors, I already mentioned that, thought to play an important role in regulating inflammation and modulating immune response. So how do we believe that this activation now works? I think it always helps to have a little bit of cartoon, and we will have that in a second. So we believe that it activates in such a manner, which we think is really neat to see, that the body produces its own natural steroid, cortisol. How does that work? So MNK-1411, if you give that, and in our case it's an injection which is given twice per week, it affects the adrenal cortex and thereby activates the releasing of cortisol, the production of cortisol, which in fact then again, what I mentioned already earlier, seems to have a potential of that it suppresses inflammation and immunomodulates. So why do we now think that MNK-1411 may work in Duchenne? So as we heard in one of the talks earlier also, and you've heard that for sure also in the past, muscles from patients obviously with Duchenne show inflammation around the injured muscles. And reduction of inflammation is a treatment approach being studied, of course. As you all know, standard of care is still the oral corticosteroids, and they have been shown to slow Duchenne disease progression. So MNK-1411 has the potential to reduce muscle damage also, and or also promote the muscle regeneration via, for example, direct effects on cells of the immune system to reduce muscle inflammation, through indirect effects to reduce muscle inflammation via the stimulation of endogenous cortisol, what I just mentioned, that the body produces its own steroids, and through possible direct effects on certain types of muscle cells seen in damaged muscles. That is what I was explaining earlier with the corticoreceptors. We don't have any patient data yet, so that means MNK-1411 was not yet applied other than in the ongoing phase 2 trial that I will explain in Duchenne patients, but we have of course done phase 1 to show the safety of the compound, and why we strongly believe that MNK-1411 will work in our Duchenne boys are of course experiments that were done in the Duchenne mouse model. It's called MDX, so you for sure have heard about that as well. And there we saw that MNK-1411 reduces the inflammation and may also reduce the abnormal gait. Now let's jump into our trial, explain a little bit more what the trial is about. As we already said, it's called BRAVE. And I love the name, I have to say. And being here again, we heard so often the boys being called heroes, little rock stars, I heard today. So we think with our name BRAVE, which is not an abbreviation for anything, we just thought we really feel they are brave. So this is how we called our study. And again, I can just point out our little hero here that I also wear on my sleeve. So what are the objectives of our phase 2 trial? So it's a study, unfortunately also I listened to that mom earlier with the 2 girls. Also we have as a phase 2 trial, first to run that trial in boys only. We have the age range between 4 and 8 years old. The primary objective of this study is to determine the effect of MNK-1411 on motor function. And we measure by 10-meter walk-run. So as you realize, we are with our phase 2 trial a little behind maybe other sponsors that are already in phase 3. We had the chance thereby to also adapt even further to the needs of patients, to listen what our patient advocacy members told us, what KOLs told us, what we directly heard from patients. So we, for example, also don't have MRI or biopsies in the studies. And we preferred, because we heard that this obviously is preferred over the 6-minute walk, we decided for the 10-meter walk-run. We have, of course, other objectives. So, for example, we, of course, assess the effect on MNK-1411 on additional measures of motor function. Also, we do the North Star ambulatory assessment, other time function tests, as well as looking at what the muscle strength, if that is improving. Of course, safety and tolerability, I think that's a clear given. We have further exploratory endpoints and want to see, of course, also what MNK-1411 does with pulmonary function. Does it have an effect there? We also look at surrogate markers associated with DMD. I explained earlier that MNK-1411 seems to have some steroidal effects. Again, even if it's not a steroid, but you can understand that because the mechanisms seem to overlap, we cannot have both. We cannot have steroid-treated boys in the trial while we are investigating our study, our investigational drug. But I'm coming to inclusion-exclusion criteria in a few minutes. Quick overview about this study. So it's a multi-center, multi-country, I should actually also add, randomized parallel group, placebo-controlled, double-blind study. It's also, I would consider it a big trial. We approximately need 132 patients, what I already said in the age group 4 to 8. We have 4 different dose arms. 2 are active doses, we call them low and high, and 2 volume-matched placebo groups. So the dosing is flat, but it's weight-based. So that means boys that weighed less than 20 kilograms get a lower dose than the ones that weighed already more than 20 kilograms. The high dose was modeled to result in cortisol exposure roughly equivalent to the usual dose of pharmacological administered steroids. So for example, we looked at what would be given in a prednisone dose to have the equivalent, and so we have 0.05 milligram per kilogram per day equivalent. The low dose is 50% lower. And also in our case, we have the patients randomized 2-to-1, so that means 66% are always on the active drug, 33 are on placebo. We have several visits. The study overall is 6-month study, so 24 weeks. That means only 6 months also on placebo. Then everyone can roll if they want to, if the physicians advise to, if the parents agree, into an open label phase. So during these 24 weeks, we have, of course, the screening visit, then a baseline, then every 4 weeks visits to the clinics. And here now, I'm happy to report that this slide is incorrect, but I didn't yet change it because we just submitted our amendment to the FDA a few weeks ago, and I would like, before I change the slides, to wait for their feedback if they have any. But what I just said, the open label is now not only another 24 weeks or another 6 months longer, but we now opened up the open label to until the product is marketed. Background, I mean, if I just said, no, standard of care is still steroids, and we say, let's have your boy participate in our trial, but only for a year, and then your parents ask, and now, what do I do? Do I go back to standard of care? No? So we felt it's really important that we can offer our patients, if they want to stay, of course, on the drug, as long as possible. So open label then really means after the first 6 months, every boy definitely gets the drug. And it's dependent on, of course, his weight. So what he started with in the first 6 months in the double-blind treatment period would be the dose that he then gets in the open label. In the open label phase, we also changed that. The visits will be then every 3 months. So here just quickly the design. Again, as I said, screening period, then the double-blind phase, which is the 6 months. Nothing changed there, with the 2 different dose arms and the placebo, and then a follow-up for those boys who would not like to stay in the open label, and then the open label phase for everyone else, again, until the drug is marketed. So what are the key inclusion criteria? Again, this is why it's called key. I only put a few there, of course, as you always know from trials, there's a whole list. But just to repeat again, it's boys 4 to 8 years of age. They need to be diagnosed of Duchenne muscular dystrophy, confirmed by complete dystrophin deficiency, or identifiable mutation in the DMD gene where reading frame can be predicted as out of frame, or a complete dystrophin gene sequencing consistent with DMD and a typical clinical profile consistent with DMD, which will be determined by your physician. Patients taking approved treatments for DMD, approved means by health authority approved treatments, that target dystrophin gene mutations are okay to be in the study. So for example, patients that are on eteplirsen or ataluren may be enrolled if they have been on a stable dose for 30 days prior to the first dose of our study. Some key exclusion criteria. So patients with symptomatic cardiomyopathy or patients who are unable to complete the 10-meter walk run test at baseline will be excluded. A quick point here, because we also learn. I will come to the study overview later, but I can already mention at this point we have 26 boys that are currently in treatment phase or already in open label. So we also listened, and sometimes of course, for boys, maybe they come from school, they have the visit, they're just tired, or they just want to play around. They don't feel like running now the 10 meters, that line, no? So we had that at the beginning, and we realized we're way too strict. If we say a boy cannot do that, he cannot participate. So we now also allow, of course, retesting. No, even if the screening visit needs to be done at the next day, because the physicians, the physiotherapists, the parents, they realize their boy is just too tired to do that, that can be done at a different time. So we are not that strict anymore, because again, it makes no sense when we look at our boys. Another exclusion criteria, though, is patients who have had previous treatment with steroids, unless, so we opened that also up. Boys don't need to be steroid naive. But we changed that, so if they were down titrated, for example, it's only a maximum of 1 month that they have to be off the study. Also here, we of course don't encourage that physicians now say, come on, get off the steroids to be able to go into that study. But you yourself know also steroids might not be the right drug for every boy, or you as parents just decide that you would like to have your boy taper off steroids. So these boys then can also be in our study. Again, it doesn't need to be steroid naive kids anymore. Whom we have to exclude, though, is patients with type 1 or type 2 diabetes. Also with chronic or active hepatitis, including acute or chronic hepatitis B, or acute and chronic hepatitis C. Excluded as well need to be patients with TB infection. We of course also test for that in the trial. Any signs, symptoms of TB, or any close contact with an individual with an active TB infection. Last but not least, here on the key inclusion criteria, patients with known immune compromised status, which is not related to the condition under study. They including but not limited to individuals who have undergone organ transplantation or who are known to be positive for HIV. Again, you can imagine, because of other circumstances, that would impact our study. So what are the endpoints? That's a huge list here. Don't worry, just quickly, I already mentioned a few. So the primary is the change from baseline to week 24, so after the 6 months of treatment, the change in the 10-meter walk run, so meaning the time. Secondary endpoints are the changes, always now we look at them more often, week 4, 8, 12, 16, and 24, within the North Star ambulatory assessments. Also, for example, the time to climb the 4 stairs, time to stand up from supine, and then other quantitative muscle testing, which we will do weeks 4, 8, 12, 16, and at the end as well, after the double-blind treatment. Safety and tolerability, of course, I mentioned already, and I think that's a given, as I said earlier. And exploratory, we said earlier, we look at the pulmonary function. So also here, we look at the difference between the baseline, which is the initial visit, and then after 4, 12, and 24 weeks. So what is the current status? I already mentioned a few numbers. Just quickly also, so participating in the US so far are roughly 15 sites, nicely distributed, I would say. Unfortunately, also not so much in the Midwest, as we already heard here a few times. It seems to be more on the East and the West coasts. But feel free, of course, to check out clinicaltrials.gov or our specific BRAVE webpage. If you go into Google and just give in BRAVE study and DMD, then that comes up, and there you can even find all the sites. You can go directly in and check where a specific site close to your location is. Other than the US, we have Mexico, Spain, Italy, Serbia, Bulgaria, and Israel, and I forgot Turkey, which is now also on board. These are the countries that are currently enrolling. More countries in Europe are to come. We also will add more sites in Latin America. Here in the US, we have the advantage for our boys that I mean, you hear it here, I think 21 companies are here to present their studies. No, there's a lot, which is great for the patients. That luck is not everywhere. So, for example, Mexico, other countries in South America, also in Eastern Europe, don't have this huge variety or options for trials. So we also go there, and people are quite happy, and the patient advocacy groups are a big support also there. So far, also here, I can say we have 26 patients, meanwhile randomized, 5 patients in screening, and 1 patient finished already the treatment phase and is in the open label. And meanwhile, I just calculated again, the boy is in the open label already for 5.5 months. So that means we know for sure that this boy now gets active treatment. And I'm very happy to say that we haven't heard any of the typical, for example, steroidal side effects. No, because even if we don't look at it from an endpoint perspective, of course, we also look at weight gain and so forth to see, does our MNK-1411 have advantages over steroids just when it comes to these side effects that are also impacting our boys from that perspective. So I mentioned already that we just had another amendment because we are learning constantly while the study is ongoing. And now this amendment, again, was already submitted to the FDA. We're pretty sure that they will support and be rather happy about this, that we now also offer treatment for patients who have been in the trial as long as we are still investigating this drug. And again, I said it's a phase 2 trial first only. We expect further regulatory and ethics committees approval for additional countries because I already said there will be more countries coming on board. And I think that was it. I thank you very much again for your attention, being here so late. It's 6:30 now. If you have any questions, also feel free. Here's my name and email address to reach out to me directly. Thank you very much.
Thank you all so much, and thank you, Jacqueline. If there are burning questions, let's do them. Run up here as fast as you can and ask your questions. We'd love to have them. And I know it's been a long day, but I so appreciate your willingness to stay. Okay. Let's go for the first question.
I have a question for Dr. Clemmons with ReveraGen. My name's Jason. My son Jake is 9. He has been on vamorolone trial for a little over 2.5 years since the beginning. My question is, when this drug gets approved, because it is an alternative steroid, are other drug companies such as the gene therapy trials going to recognize that the boys don't have to be on a traditional corticosteroid to be part of their trial? And what type of dialogue is out there for that?
So, good question. I mean, I can't speak for them, but I would hope that they would, that would certainly be a possibility. Typically, you generally can't have 2 investigational drugs in the same trial. Although we did approach some folks about, doing some sort of a platform style with vamorolone, but that's a little bit too avant-garde, I think. But I think that, I would certainly hope that if any of these drugs that, that are more not dystrophin correcting and are clearly complementary to dystrophin correcting therapies would then be combined with the dystrophin correcting therapies.
Thank you.
Question.
Yes, thank you all for your presentations. My question is for Dr. Pfister. First of all, the Emflaza Cares program has been terrific. It's been implemented great, so I want to thank you for that. And I just want to know if that will continue, or will be there a time when we'll be able to receive the Emflaza at the local pharmacies. And the second question is, as our boys transition into young men, and they continue the treatment, do you have data that shows that that is effective, or anything benefits for continuing on Emflaza once they are no longer ambulatory? Thank you.
Yeah, actually, I appreciate the questions with regards to the PTC Cares program. I've got some colleagues that can address that deal with that on a regular basis. But more to the bigger question of the long-term effectiveness, there's additional data that will have come out shortly, which will kind of address some of your questions with regard to that. So there should be additional material coming soon.
Thank you very much.
Thank you. And if there are no further questions, thanks to my panel, all of you. We are looking forward to seeing these drugs approved, and Emflaza is already approved, so the rest of them, where are we? Valmorelone, Catabasis, MNK 1411, and Valmorelone, I got that. And so thank you all for joining us. We're going to start tomorrow. Yoga's tomorrow morning. I guarantee that after a few days, a little stretching wouldn't hurt. That's 7:30, and we'll begin at 8:45 we start tomorrow morning. Thank you so much again, and enjoy your evening.